Do 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 do. Alright, fuck. Meant to do more pages yesterday, but got caught up with things. Had visitors travel down, see me. But that's okay, because we're back at it today with more content through the MCAT Bros long psychology document. And we're going to continue off with sound audition. And I don't know where we'll leave off. But I will probably go until noon, maybe 12:15, and maybe we get some good progress. I don't know, but hopefully. We woke up a little bit ago, so over time I'm gonna get more awake. So, starting with sound. Okay, so from yesterday we talked a little bit about the depolarization of sound waves. See, if you can't tell, I'm still waking up. But yesterday we talked about the sound waves flowing through the air and stimulating multiple different components in the ear, such as the tympanic membrane, which can be downregulated by auditory adaptation to reduce the loud stimuli so it protects the eardrum. So, building off yesterday, audition, our sense of sound. Makes sense? Because if you're auditioning for something, someone wants to hear what you have to say. So, for us to hear sound, we need two things. Oh my god damn, my water's not waking me up fast enough today. Shit. So we need two things to hear a sound. A pressured sound wave and a hair cell in the organ of Corti. So we need a pressured sound wave produced by some stimulus in the environment and the mechanical receptor hair cells located in the organ of Corti. So what is a pressured sound wave? So example, in between your hands are a bunch of air molecules. When the hands move towards each other, there is less space so the molecules compress and there's higher pressure. The air molecules are becoming pressurized. So basically clapping of air. Clapping your hands around air. So, air molecules are pressured and try to escape, creating area of high and low pressure known as sound waves. I think everybody knows what a sound wave is if you're in the science department or common sense. It's just basically the sound waves with a certain frequency that go up and down. Usually sound waves are more longer because of radio waves are very long. And wavelength tells you how close the peaks are together. So a small wavelength has a greater frequency, while a higher wavelength means they have to travel farther and penetrate deeper into the cochlea. Different noises have different frequencies and wavelengths. You can listen to different frequencies at the same time. If you add different frequency wavelengths together, you get weird frequency. Ear has to break this up, able to do that because sound waves travel different lengths along the cochlea. Okay, so what is the pathway of sound? So we have to have the sound enter through the pinna, so the most external part of the ear. Then we have sound enter the auditory canal, which is like our ear canal that usually people get water in and they have to shake their ear to get the water out. And then from the auditory canal, it's separated by the tympanic membrane, our eardrum, from the outer ear and the middle ear. Behind the tympanic membrane, we have our ossicle three bones, our malleus, our incus, and our stapes. You can think of malleus looks like a hammer, incus looks like an anvil, and stapes looks like a staple. So, those are the three smallest bones in the body, and that the stapes is sitting in the oval window. And the oval window is the entrance to the most inner ear of the body. The oval window is used to vibrate back and forth to send different signals through that endolymph and perilymph to trigger mechanical receptors to remove the hair cell. So at the tip of the cochlea, it can only go back against the round window and push it out. The reason it doesn't go back to the oval window is because in the middle of the cochlea is a memory called the organ of Corti, which I was talking about earlier, that contains the hair cells that convert the sound waves into electrical impulse and are transported by the auditory nerve into the brain through the thalamus, and then from the thalamus a specific nucleus that goes to the temporal region of the brain. So, I never heard of place theory, so let's read what place theory is about. Place theory is a theory of hearing which states that our perception of sound depends on where each component frequency produces vibrations along the basilar membrane. By this theory, the pitch of a musical tone is determined by the place where membrane vibrates, based on frequency. Place theory postulates that one is able to hear different pitches because different sound waves trigger activity at different parts on the basilar membrane. So let's think about that. That makes sense. So different frequencies can vibrate at different parts on that basilar membrane. So based on the frequency and wavelength of the sound that we hear or the stimuli, it will vibrate on that membrane at a specific region that will oscillate to the hair cells. The bulb process of fluid going around the cochlea keeps occurring till the energy of the sound wave dissipates and moves out. That makes sense. So it basically means if the fluid is vibrating more, it means more hair cells will vibrate, sending that stimuli to the brain. So, the three classifications of the ear, we have the external and internal ear, from the pinna to the tympanic membrane. So we also have that auditory canal in there. We have the middle ear, which has the three small bones that we evolutionarily derived from different fish components. If you ever taken comparative vertebrates, it would teach you that through the evolutionary history. And then in our inner ear, we have the cochlea and the semicircular canals. As a review, the semicircular canals is for circular rotation and acceleration and balance, while our sacula, I believe is the proper way to say it, the sacula is used for linear acceleration. Review from yesterday. So, auditory structure part 2. So focusing on the cochlea in the inner ear, we can look at different components of the cochlea. So the stapes moves back and forth with the frequency of the stimuli. It pushes on that window back and forth. Oh my god. God damn. There's fluid inside the cochlea, but it gets pushed around the cochlea and comes back around. The organ of the corti splits cochlea into two, the upper and lower membrane. So we have the basilar membrane and the tympanic membrane, I'm assuming. So the upper and lower membranes and the little hair cells. The fluid flows around the organ and causes hair cells to move back and forth. Yeah. The upper membrane, the hair cells are called hair bundles, and it's made of little fibers. So I didn't hear about that before. Hair bundles. Each filament is called a cancellum. Tip of the cancellum is connected by a tip link, which is attached to a gated potassium channel. So basically, these different filaments have a potassium channel on them. And I'm assuming it's got to do something with promoting an action potential or hyperpolarizing. Because when potassium flows into the cell, it polarizes the cell to be off, or a neuron. Unless when this opens up, it allows for it to become negative. So, let's see. When it gets pushed back and forth by the endolymph movement, they stretch and allow the potassium to flow inside the cell. Okay. Calcium gets activated when potassium is inside. So calcium flows into the cell and causes action potential. Okay. Interesting enough. Which then activates a spiral ganglion cell. So it's just like the eye. So we have that rod or cone that gets turned off, which activates that polar cell, bipolar cell, which turns on, which gets translated to the optic nerve. So in this case, we have the hair cell that gets turned off, basically, I believe, because if it's getting positively charged, the action potential is getting polarized. And then that activates the spiral ganglion cell, which then activates the auditory nerve. Okay, so here's just a diagram of what's going on in the ear. So, the brain relies on the cochlea to differentiate between two different sounds, as we said earlier. Yep. Bass drum has low frequency, whereas bees have high frequency. So low frequencies are lower hearing sounds, high frequencies are high hearing sounds. The information on the bass drum and the bee hits the cochlea. How the information how sound waves convert into a neural signal then to the brain was discussed in the previous section. Okay, so just talk about what we talked about earlier. So auditory processing. It's the process of how sound waves are converted into a potential signal in the brain. The brain uses basilar tuning. This is what I was talking about on the basilar membrane. There are varying hair cells in the cochlea and allow the brain to distinguish between high and low. Hair cells at the base of the cochlea are activated by high frequency and those at the apex by the low frequencies. Think long wavelengths can travel farther. Okay, that makes sense. Because they have a long wavelength, they can travel deeper into the ear. Where you want to have a high frequency at the very outside of the ear because you don't want to damage those cells on the inside too badly. Okay. So as sounds of different frequency reach the ear, they'll stimulate different parts of the basilar membrane. That's the place theory that we were talking about earlier. About The apex is where low frequencies but high wavelengths, or the base is where 6,000 hertz high frequency low wavelengths. As sound enters the cochlea, it travels and activates the hair cells, as I keep repeating myself about. The primary auditory cortex is the temporal lobe, which makes sense. Receives all info from the cochlea. It separates the region which detects different frequencies. If this didn't occur, brain wouldn't be able to distinguish between the different sound frequencies. So with basal tuning, the brain can distinguish using a tototopic mapping. So let's talk about cochlear implants. So this is a topic that was not in my MCAT books at all for practice, so I need to go over this. Cochlear implants is a surgery procedure that attempts to restore some degree of hearing in individuals with a sensory narrow hearing loss, aka nerve deafness. Individuals who have a problem with conduction of sound waves from cochlea to the brain, the receiver goes to a stimulator, which reaches the cochlea. Okay? Receiver receives information from the transmitter. Transmitter gets electric information from the speech processor. The speech processor gets info from the microphone. Sound microphone transmitter sends info into the receiver. Then it sends to the stimulator into the cochlea. The cochlea converts the electric impulse into a neural impulse that goes to the brain. That is a complex pathway, but I need to review it. So, when sound enters someone that has a cochlear implant, it hits a microphone to amplify the sound, which is then transmitted outside of the skull, which sends that info back into the skull, which activates a stimulator to promote the cochlea to convert the electric impulse into a neural impulse. Okay, somatosensation, we talked about it earlier. It's basically balance in knowing where our body is in position through touch, temperature, and the different somatocortex. Sensory adaptation and amplification. We already talked about this, but let's continue with it. The sensory adaptation is our change of feeling a stimulus over time. So downregulation is of a sensory receptor in the body. As you push down with a hand, receptors experience constant pressure. But after a few seconds, receptors no longer fire. So as we talked about earlier, think about a hot plate that you're touching, that over time you won't notice the burning sensation as bad. So you're downregulating that expression of those sensory receptors. Important because if cells are overexcited, cells can die. If too much pain signals pain receptor, cell can die. So, on another end, it could kill off the cell, even if it's reducing the stimuli being felt. They're overexcited. So amplification is upregulation, which I was talking about, like amplifying the signal through that microphone in the ear implant. So, light hits a photoreceptor in the eye and causes the cell to fire, which the cell fires at action potential connected to two cells, kills the fire at action potential, so on. So yes, amplification is just increasing the strength of the signal. Alright, the somatosensory homunculus. So I learned about this in neuroscience, and I don't know why we still talk about it because a lot of papers show that the somatosensory homunculus is inaccurate in the neuroscience department, but it's still used because it's outdated. But overall, the homunculus is a diagram showing a map of that cortex of where in your body you're going to feel a stimulus. And that somatic cortex right above that central groove. Central gyrus, I should say, not groove. And it mapped out like where you'll feel it in your face, different parts of your arm, legs, your chest, and they determine this by using different probes. And they would have them awake and they're like, "Where are you feeling this stimulus right now?" They would ask them, and they would tell them that they're feeling it at this part of their body. This part of the cortex is called the sensory cortex, containing the homunculus. So we basically covered all of these already in a brief summary. Proprioception, we already talked about this. It feels like it's repeating itself constantly. It's balance and position. We talked about it yesterday. It's talking about how we feel where our body is in space. And it's subconscious. And it depends on certain different components sending signals through the spinal cord and the brain that we are either upright, laying down, etc. So, kinesthesia is talking about the movement of the body. This is more behavioral, and it's basically examples tell you about the controlled movement. Like, if I want to move my right hand up, I just think about it and it's moving my right hand up. So it's movement of the body. So let's see what this detail here. Recap. Not the same, but shares a lot in common. Proprioception talks about balance and position, while callus talks about the sense of movement. Proprioception is cognitive, callus behavioral. So proprioception is the subconscious cognitive thinking that where your body's located. Kinesia is your changing of behavior, of moving out of the way. Okay. Pain and temperature. Pain and temperature. Okay. Pain uses nociception receptors, which send that stimuli through usually reflex arcs. And there's a gated theory, which we'll talk about later. Thermoception is using thermoreceptors. Both temperature and nociception are slow compared to other sensory receptors sending a signal. In order for us to sense a temperature, we rely on that TRYPV1 receptor. So think to sense temperature, T and T. So it's also sensitive to pain, and this is promoted by a protein conformational change. So if you know your biochemistry, whenever a protein changes shape, it alters its function because shape defines function. Shout out to my biochem teacher. So, when a cell is poked, 1,000 cells are broken up, release different molecules that bind to this T receptor. I'm just going to call it T receptor because I don't know how to pronounce it correctly. And if I think T receptor, it has to be related to temperature. And it causes this action potential to be activated through a conformation change. There's 3 types of nerve fibers: fast, medium, and slow. Acronym to remember is fast, the slowest is A, B, A through D, and C. So A beta fibers are the fast ones and thick covered in myelin. A through D is small diameter, less myelinated. And C fibers are small diameter, unmyelinated. So A beta alpha or A beta fibers are fast ones. A delta are slower because it's further in the alphabet. And C is the slowest because it's the furthest in the alphabet. That's one way to remember it. Pain also causes change in the conformation of receptors. It causes capsaicin to bind to these receptors, especially in your tongue. This triggers a response to send a neural response. So the sensory component would be described as the aspect of the intensity of pain. The affective component is our experience of emotions. And then lastly, for pain and temperature, we have that gate control theory of olfaction. And it's the theory of the process of nociception. And the gate control theory is basically saying that we have specific gate pathways that can open or close due to the amount of pain that we experience. For example, we can have one pathway that could just be the reflexive arc. But if you break your leg, it's gonna send it all the way to your brain and open that gate, telling you not to move your leg or it'll cause even more damage to the muscles that are attached to that broken leg. So that's just basically a summary of what the gated control theory that I learned in health psychology at my school. Okay, so taste and smell. So why do dogs pee on fire hydrants? They are releasing pheromones to signal that this is their territory or attract other mates. Its pheromone is generally a molecule that is used to alter a specific behavior in another organism. And they usually act on specialized olfactory cells, and they can only cause a response by smelling them. So here's the pheromone definition that I said earlier. And it's really important. It's because it's particular. It promotes specific behaviors like mating, fighting, and communication. So, for the general structure of olfaction, it's located in the olfactory epithelium of animals, and it has the accessory olfactory epithelium. It sends projections from the accessory olfactory bulb to the brain. And this is one, I believe, that goes through the thalamus. I believe. Because I believe sight is the only one that doesn't. But anyway, continuing on. This general structure with the accessory olfactory is known as the vomeronasal system. In the vomeronasal system, it has basal cells and apical cells, and they have receptors at tips. So there's apical cells in the ear as well, but there's apical cells in the vomeronasal. And there's the tips. It's basically the tips of different receptors. So molecules will come in and activate the receptor on a basal cell / apical cell. And the basal cell will send an axon signal through accessory olfactory bulb to the glomerulus. which is weird because there's a glomerulus in the kidneys, which eventually goes to the amygdala. Amygdala is involved with emotion, aggression, mating, and the temporal lobe also involved with memory. Signal transduction is where the signal binds to the receptor, binds to a GPCR, depolarizes, and the signal goes to the brain. In humans, we have a vomeronasal organ but no accessory bulb. We rely little on pheromones because we didn't evolutionarily adapted against it. So, structure and function of olfaction. When you have a cold, you're able to taste things very well. When you eat, molecules travel up to the back of the throat and sometimes go back into your nose. You're using the sense of smell in conjunction with taste. If your smell is knocked out, you can't taste things as well. Smell is also known as olfaction. If you think about it, olfaction starts with an O, and that O reminds me of like a nostril. That's how I remember it. So, areas in the nostril are called by olfaction epithelium. Separating the olfactory epithelium from the brain is the cribriform plate, bones with little holes that allow olfactory sensation to send projections to the brain. The cribriform plate is an extension from the brain. So I need to review cribriform plate because they didn't really talk about this in my one book. So as a review, cribriform plate is the plate that separates the olfactory epithelium from the brain. Okay? So it's basically a specific part of the skull that separates the two different epitheliums of the brain and the olfactory nerves. Okay? Everybody knows what the olfactory bulb is if you're taking any neurobiology class or neuroscience. It is the bundle of nerves that sends the projections to the brain for an olfactory response. And end of each connection are receptors, which are sensitive to one type of molecule. The molecule travels into the nose, binds one of the receptors on a nerve ending. So, looking deeper into the olfactory bulb has different cells with specific receptors of different molecules that send those to. Oh my god, I got the hiccups. That send these signals to. Just making sure everything's working. Yep. That sends these signals to the brain. So, an example is our one receptor is basically sensitive to benzene rings. It binds to the receptor to trigger cascades of events that cause the cell to fire. The action potential end up in the olfactory bulb. All cells sensitized to benzene will fire. We call the glomerulus to fire and send that signal to the brain through the mitral and tuft cells that project to the brain. This organization is there because it's easy for one cell to send a projection to the brain instead of 1,000. So it's using these as an intermediate to amplify that signal to send to the brain. Okay. So how does a molecule bind to a receptor and cause an action potential? So the molecule binds to the GPCR receptor on an older molecule. The GPCR on the olfactory epithelial. The G protein dissociates and causes a cascade of events inside the cell. The G protein binds to an ion channel which allows cells to outside the cell to come inside. Alright, I was just sneezing my brains out because my allergies are acted up, so we're back. So where was I? The G protein binds to an ion channel which allows the cell outside the cell to come inside. Don't make sense, but it's probably talking about concentration gradients, promoting that action potential as nerves always do. Sodium flowing out causes it to become sodium flowing in causes it to become positive. No, yeah, to become positive, which promotes the polarization. And once it reaches the cribriform plate, it goes to the glomerulus, activates the mitral cell for that amplification, and then synapses to the brain. Idea: 100 different olfactory epithelials, each are centered on one particular molecule. They all send to the glomerulus, which all synapse to the mitral. Okay. So smell and taste doesn't synapse on the thalamus, and they're both ipsilateral, while vision and hearing are contralateral. Okay, that makes sense. So if we think about it, ipsilateral means that they're on the same side. And if we're experiencing both smell and taste at the same time, they should be on the same side. While vision and hearing and touch are contralateral because we can have vision going at a specific time but not hearing anything different or not even being touched by anything, so they can all be occurring at different times, so they don't have to be linked together. And I was right about smell and taste not using the thalamus earlier. So let's look at these theories. The labeled line theory of olfactory describes a scenario where each receptor would respond to a specific stimuli and directly linked to the brain. The vibrational theory of olfaction asserts that the vibrational frequency of a molecule gives that molecule its specific odor profile. The steric theory of olfaction, or the shape theory, asserts that odors fit into receptors similar as a lock and key, which is iffy in the biochemistry department. And anosmia is the inability to perceive odor. They have some auto corrections that they need to fix. But anyway, the pathway for olfaction goes from the olfactory bulb to the amygdala and the piriform cortex. Then the signal is transmitted to the orbital frontal cortex. Alright. Gustation. So our taste buds on our tongue. Okay? We have 5 main tastes: bitter, salty, sweet, sour, and umami, which is the ability to taste glutamate. Okay. So the gustatory system consists of taste receptors in the form of taste buds. Taste buds in turn are contained in structures called papillae. So taste buds are concentrated on the outside of the tongue. Taste buds can be fungiform, foliate, or circumvallate. Each taste buds are the 5 receptor cells that can detect each taste. Each taste can be detected anywhere on the tongue. Each taste bud has cells specialized for each of the 5 tastes. Okay. So basically, each taste bud contains all 5 receptors for a specific type of taste that we're going to experience. So most are on the anterior part of the tongue. Fungiform papillae are mushroom-shaped structures located on the tip and sides of the tongue, which contain taste buds. Foliate papillae are folded structures on the back of the tongue, or on both sides, which contains taste buds. Circumvallate papillae are flat mound structures that are found on the back of the tongue and contains taste buds. Filiform papillae do not contain taste buds and exist all over the tongue. The center of the tongue contains only filiform Okay. This is why stimulation of the center of the tongue does not taste sensation. It's why the back of the perimeter produces a broad range of taste sensations. Okay. Tastin is a substance that stimulates the sense of taste. Gustadoxin is a protein station with a sensation of taste. Front, second, or third carries signals via the seventh cranial nerve. Posterior carries signals from the ninth and 10th cranial nerve. Then we have the labeled lines model. Each taste bud receptor has 5 axons, all which send separate taste information to different gustatory taste cortexes. Remain separate in the brain, and they all synapse are different parts of the cortex. Which makes sense. Like, if the 5 receptors are in one taste bud, they all need to synapse to the different parts of the brain. So, example, glucose hits tongue, activates sweet cell. Because it has a sweet sensitive receptor, the trigger cascade events depolarize and travels to the axon to the brain. Glucose binds GPSR, conformation change, and opens ion channels causing the cell to fire. Reaction potential. Sweet, umami, and bitter cells rely on GPCR, so G proteins receptors. Sour and salty rely on ion channels. Acronym: sodium, which is an ion channel, and sour is a salt, so fake salt. Okay, makes sense. They bind to our site directly. Sodium binds to receptor and causes ion channel to open and positive ions flow in. Cells depolarize and fire a action potential. Yes. Salty tastins bind to salt receptors which detect the presence of sodium ions, and they should not be chosen by the researchers. Sour tastins bind to sourness receptors and react with hydrogen cations. Once cations bind, it closes potassium channels, which reduce the action potential, or increases the action potential, because it's closing them, keeping it positive. What happens if we put salt receptors inside a sweet cell? Receptors in the membrane bind to glucose, but let's insert a salt receptor. So an exit from the cell leads to the brain. As sodium comes in, it activates the receptor, and sweet cell depolarizes and fires the action potential. Putting a salt receptor in a sweet cell can trick your brain into thinking salt is sugar. Taste and smell do not synapse on the thalamus, as we said earlier. And the orbitofrontal cortex is the first place of integration. Alright, moving to a different topic. Sleep and consciousness. So, I have learned this last week, so I'm pretty aware of like the new terms and everything, so this should be not too terrible. Consciousness is the ability to be aware of ourself and our environment. So when we're in a coma, we're not conscious because we're not aware of our environment. Alertness is you're awake and you're aware of where you are and what's going on in your environment. So that's also talking about a coma is the opposite. Daydreaming is felt more relaxed, not as focused as alertness, can be a light meditation. Drowsiness is just before falling asleep or waking up, can also be self-induced to deep meditation. So how I started off this live stream today, I was very drowsy because I was just waking up, just a little bit ago. Sleep, you're not aware of self or the world around you. EEGs measure brain waves. Alpha, beta, delta, theta. Alpha and beta are the fastest, and they occur during awake states. Theta is at transition state, and delta states are that slowest brain waves. So delta waves, as you can see, are the deep sleeper coma. Theta is the slower, lower frequency. You might not be aware of shifting from one stage of sleep to another, but your brain knows. You have set of neurons that fire in your central nervous system, leads to neural rhythms known as brain waves. So, talk about sleep stages in the circadian rhythm. Sleep stages occur in 90 minutes cycles, and there's 4 of them. The first 3 are N1 through N3, and then we have REM. So, N1 is non-rapid eye movement, stage 1, and it's dominated by theta waves. Okay? Strange sensations. Hypogonic illusion, hearing or seeing things that aren't there. Seeing flash of light, someone calling your name. Or the Tetris effect. Play Tetris right before bed, you might see visual images of blocks during sleep. If you've been on a boat all day, you might still feel like you're on water, even when on dry land. Also, feeling of falling, the hypnic jerk, muscle twitches you sometimes experience as you fall asleep. So at stage 1, you're basically just falling asleep, and it's dominated by theta waves, but you're experiencing like all these irregular sensations. N2 is deeper stage of sleep. People in N2 are harder to awake. We see more theta waves as sleep spindles and K complexes. Sleep spindles are the burst of a rapid brain activity. Some researchers think that sleep spindles help inhibit certain perceptions so we might attain a deeper tranquility state during sleep. Sleep spindles in some parts of the brain associated with the ability to sleep through loud noises. So, sleep spindles, just think, is like a suppressor of being woken up by different loud noises. K complexes also suppress cortical arousal and keeps you asleep. Also helps sleep-based memory consolidation. Even though they occur naturally, you could also make them occur by gently touching someone sleeping. That touch is not saying so stay asleep. So N3, or non-REM sleep stage 3, is when we have the most slow wave sleep. It's very difficult to awake, characterized by delta waves, where sleep, walking, and talking occurs. Declared memory consolidates, regular breathing, really slow brain waves. And then we have REM, rapid eye movement stage. Eyes move rapidly beneath your eyelids, but most of your other muscles are paralyzed. Most dreaming occurs during REM sleep, so paralyzation inhibits actions. So, like if you're having a nightmare, you would wish that your body is paralyzed so you don't hurt yourself while you're sleeping. REM sleep is used for memory consolidation and for formation of episodic memories. Combination of alpha, beta, and dysynchronous waves, similar to beta waves seen when awake. So basically, REM is like you're awake again. Acronym: bats drink blood. So beta, alpha, theta, sleep, spindles, K complexes, delta, beta. Okay. Sometimes paradoxical sleep because the brain is active and awake, but body prevents it from doing anything. Waking up during REM sleep allows you to remember your dream. REM sleep more before you wake up. REM sleep more before you wake up. More N3 sleep right as you go to bed. Consolidates procedural memories. Cycles through these 4 to 5 times a night. Remember, each one is 90 minutes. And they tend to go from N1, N2, N3, N2, REM, N1. How long each stage lasts depends on how long you've been asleep and your age. Okay. So they're showing you different diagrams of the different stages. So you could have wakeness, stage 1, stage 2, stage 3. You'd enter REM, which is stage 4. Go back to stage 2, kinda, then REM. It's just basically showing the different stages that someone can experience. Circadian rhythm. Why you keep sleeping in the afternoon. Why you get sleepy in the afternoon. There are regular body rhythms across 24-hour periods controlled by melatonin, produced by our pineal gland in our brain. So, it controls our body temperature, our sleep cycle, etc. Daylight is a big cue, even artificial light. Also change as you age. Younger people are night owls, but older people are in bed early. Can prevent you from sleeping in. So, the more light you see, the more the more suppression of melatonin will be produced, which in turn can technically produce it to be. Once you reduce light, it can produce it to be produced quicker. So dreaming. Everybody dreams during REM sleep. Can tell someone is dreaming because eyes are moving rapidly under eyelids. Brainwaves look like they're completely awake. These are memorable dreams. Non-REM ones are not memorable. Activity in prefrontal cortex during REM sleep is decreased, part responsible for logic. Why things in our dreams defy logic and don't seem weird. Why do dreams occur? There's a few theories. Sigmund Freud says dreams are our unconscious thoughts and desires that need to be interpreted, but little scientific support, just like Freud and every theory he proposes. Evolutionary biology says it's a threat simulation to prepare for the real world, problem solving, or neural purpose. And then other is it maintains brain flexibility, allows us to learn and creativity. When we are awake, consolidate thoughts to be long-term memory and cleaning up thoughts. People who learn plus sleep retain more than those who do not sleep, but role of REM is unclear. And then preserves and develops neural pathways because infants constantly developing new neurons spend most time in REM sleep. Memory consolidation theorists believe memory consolidates in deep sleep. So dream theories. Our favorite psychologist that's most likely wrong in everything, majority, is Sigmund Freud theory of dreams. Bias in my opinion, but he may have done more harm than right with his theories. He says dreams represent our unconscious feelings, urgent thoughts, like an iceberg. What happens literally means manifest content. Monster chasing you. What is the hidden meaning is the latent content. Job pushing you out. So manifest content is of dreams is that monster is chasing you, while the latent context is the actual meaning behind it. Dreams have meanings. Interpreting them can help us resolve and identify hidden conflicts. So Freud's theory is saying that our dreams have specific meanings that are related to our personal life. And if we can understand what we're dreaming about, it can help us resolve and identify hidden conflicts that we're experiencing in our life. Okay. So the activation synthesis hypothesis is the brain gets a lot of neural impulses in the brainstem, which is sometimes interpreted by the frontal cortex. Brainstem equals activation and cortex equals synthesis. Our brain is simply trying to find means for random brain activity. Therefore, dreams might not have meaning. So, one is saying there's meaning, and the other one says there is no meaning. So, activation synthesis is more of the biology approach that it's just trying to, our brain's just trying to produce something in response to activity in the brain. So, let's go through some sleep disorders. People with sleep deprivation might be more irritable and have poor memories and attention. Could be dangerous when it comes to flying airplanes or driving cars. Makes sense. Because sleep deprivation can lead to irritable and poor memory and action. Interesting, more sleep equals less accidents, less sleep equals more accidents. Also, more susceptible to obesity. Body makes more cortisol and the hunger hormone ghrelin. So, it can also increase your risk for depression if you're sleep deprived. REM sleep helps brain processing emotional experiences, can help prevent depression. It can get you can get back on track through a sleep debt. So basically your body wants you to sleep so it can catch up by increasing the amount of REM cycles that you go through. How much is enough sleep? 7 to 8 hours for adults, varies with age and individuals. Babies need a lot more. An infant should get at least 12 hours. A preschooler should get at least 10. And a school-aged child should get at least 9. And older adults at least 7. Most serious form of a sleep disorder is insomnia, which is the inability to fall asleep or staying asleep, which various medicines may take them to lead to dependence and tolerance. Rely on medication, you become more habituated to it and needs more to get the same effect. Treatments can involve psychological training and lifestyle changes. This is a better alternative to medication. Some medication can be like melatonin. On the other end of the spectrum is narcolepsy, which they can't help themselves and fall asleep randomly at different times of the day. So they variously fits to sleeping going into REM sleep. They have fits usually 5 minutes that can occur any time, 1 in 2,000 times. Cause is not completely known, indications that it's genetic and linked to absence of alertness neurotransmitter. The neurochemical intervention can cause someone to overcome narcolepsy potentially. Sleep apnea affects 1 in 20 people. People with it are often unaware, stop breathing while sleeping, and body realizes you're not getting enough oxygen. Wake up just enough to gasp for air and fall back asleep without realizing. Can happen 100 times a night. And this promotes not enough N3 sleep. Snoring is an indication, or fatigue in the morning after a full night of sleep. Sleepwalking and sleep talking are most genetic and occurs during the N3 stage and are harmless. It occurs most often in children because they have a more N3 stage than adults. Breathing related sleep disorders. See below notes. Okay. So, hypnosis and meditation. So, hypnosis and meditation induce states of consciousness. Hypnosis plus medications are examples. Does not occur naturally. So, hypnotism usually involves getting a person to relax and focus on breathing, and they become more susceptible to suggestion in this state, but only if they want to. More alpha waves in this stage, and an awake but relaxed state. So, hypnotism, if you've seen Late Night with the Devil, the one guy hypnotizes the whole crowd to think that the guy is pulling worms out of his gut, but it's just he is in a suggestive state. Some use hypnosis to retrieve memories. Very dangerous because memories are malleable. Can't create false memories. Which false memories are memories that incorporate hypnotic expectation even when they're not intended. Some people feel that hypnosis can control pain, might help us inhibit our attention to painful stimuli. Only works if you think it will work. 2 theories for how hypnosis works. We have dissociation theory, which hypnotism is an extreme form of divided consciousness. and social influence theory, which people do and report what expected of them, like actors caught up in their role. My my opinion, I think it's social influence theory, that they're just in a very suggestive manner, and that they're just getting caught up in the role that they're being told to fulfill. Refocus attention, so sometimes it's used to treat pain. Reduce activity in areas that process sensory inputs. Although it doesn't block out, it might inhibit attention. That inhibited. And meditation is training people to self regulate their attention and awareness. Can be guided and focused on something in particular like breathing, but meditation can also be unfocused and mind wanders freely. More helpful ways than normal in relaxation. In deep meditation, they have increased theta waves. So only experts typically, so like monks. And there's no long-term studies, but those who regularly go into deep meditation have shown increased activity in the prefrontal cortex, right hippocampus, and right anterior insula for increased attention control, the goal of meditation. Can be helpful for people with ADHD or in aging. So, we're going to continue with drug dependency, but I need to refill up my waters, so I'll be right back. Alright, and we're back, but I also have food because my family has brought me food to eat. So, I'm gonna slowly eat. I'm gonna quickly eat a couple of these things and then we'll jump into drug dependency. Alright, so as I'm preparing this extra food, I should give some background about my content on drug dependency. Last fall, I was in a abnormal psychology class. It was called, but they changed the name of it to adult pathopsychology because they thought abnormal psychology was too informal of a class name or too informal of a field of study. So they changed the class name to adult pathopsychology. Well, not adult, but just in general. And I took it, and it went pretty good. It had a lot of extra credit, and ended up with an A in the class because all the extra credit really helped me out. Legit, I had so much extra credit in that class that for the final, I literally only had to get 8 points, 8 questions right out of 35 on that final. It was just not a, it was a non-traditional final. It was just like the fourth exam. But it was a non-traditional final. It was just a exam 4, and our exam 4 was over personality disorders and eating disorders. So this content won't be too terrible for me. Hopefully, if I remember it. Because I remember in that point of the semester I was freaking out about physics. Freaking out about physics and everything. So I remember I was like, I'll just study a couple hours the night before and 1 hour before the exam. Somehow, by doing that, I got 100 on it. I don't know how, but I guess just having a couple hours to study that content, I just needed to answer all the questions. Ended up getting 100 on it. Felt proud. Still don't know how to this day that I did it, but fuck it. We ball. But anyway, that's enough background story, and I'm almost done with cutting some pancakes as my midday, or not midday, I should say, my morning breakfast to keep the neurons firing, keeping me alive. Hopefully, it wakes me up more eating this. But it's enough story time. It's about the time to get back into some more content. So, let's get back to it. So, okay. Drug dependence. It's overall psychoactive drugs we're going to start with. So we did talk about this in my abnormal class. So psychoactive drugs. Drugs that can alter our consciousness and perceptions. They can alter our perception, increase our mood, calm us down, make us feel more alert. And they're classified by the actions that they do on our body. Okay. There are 4 main types that we should know. Depressants, stimulants, hallucinogens. I only see 3. Okay. But let's go with depressants. Depressants, they are drugs that lower our body's basic function and neural activity. So they reduce our central nervous system by increasing the amount of GABA that's being released. Because GABA is an inhibitory neurotransmitter. They can do this by decreasing heart rate, decreasing blood pressure, reaction time, and has three categories of depressants: alcohol, barbiturates, and benzodiazepines. Which benzos are used for schizophrenia. So, it generally causes vasodilation at a low, and it's a constrictor at high. Oh, I don't know how to read. Vasodilation is low, vasoconstriction is high blood pressure. So the most popular depressant is alcohol. It decreases inhibition, so it decreases cognitive control. A lack of coordination, slurring of speech. So it impacts the temporal lobes as well. Okay. So, and it interrupts REM sleep of forming memories. Barbiturates are used to induce sleep or reduce anxiety. It depresses your central nervous system. It's an anesthetic or anticonvulsant. Not often prescribed due to the negative side effects, such as reduced memory, judgment, and concentration. Alcohol that can lead to death. Benzodiazepines are most commonly prescribed suppressant, prescribed for same things as barbiturates, sleep aid, or anti-anxiety. Enhances your brain's response to GABA. They open up GABA-activated chloride channels in the neurons and make neurons more negatively charged. So the inhibitory neurons. Okay? There's three types: short, intermediate, and long acting. Short and intermediate are usually for sleep, while the long acting is anxiety. Okay? Benzodiazepines are alcohol to bind to a silent GABA receptor and complex that regulates the sensitivity of receptor complexes. Stimulants are drugs that excite your central nervous system, so like cocaine. Or that's the main one that I think off the top of my head. Caffeine. And they increase heart rate, blood pressure, alertness, more awake, more energetic. Glittery. I think that's supposed to mean jittery, but we talked about some examples: caffeine, methamphetamine, cocaine, nicotine, so on and so on. So, now that I've finished that food, we can focus fully back in. Cocaine can be used as an anesthetic. They used to do it for surgery back in the day. That's why they had it in Coca-Cola. Interesting enough. The effect is similar to stress, increases glucose metabolism in the brain. Cocaine blocks dopamine reuptake. Amphetamines both block dopamine reuptake and stimulates presynaptic dopamine release. Caffeine inhibits the enzyme that breaks down CMP, cyclic adenosine monophosphate, which promotes gluconeogenesis because it phosphorylates things. Nicotine acts on acetylcholine. THC works on anandamide, increases dopamine and GABA activity. Stimulants depressants are functionally opposite, but they don't actually work on the same things at a neurochemical level. Drinking coffee after drinking alcohol won't make you sober. It will make you alert, drunk, person. Okay? It's a vasoconstrictor. So it constricts your blood vessels. Hallucinogens, referred as psychedelics, they distorted perceptions. Hallucinogens, seeing or hearing things when they're not actually there. You have heightened perception sensations based on reality, but it's different from what's going on in the world. Can give things energy or calm them down. Emotional responses, feeling connected and mood swings. The active effect can be different depending on the individual's personality. Some examples: PCP, LSD, psilocybin. LSD modifies serotonin neurotransmitters, which disrupts the stability of the brain. Dilation of the pupil. Opioids are natural. Opiates are natural. Opioids are synthetic. Like depressants, decrease central nervous system, decrease heart rate, cause relaxation, induce sleep. It's not a depressant, works on different mechanisms. Reduces perception of pain. Used to treat pain because they act on body receptors for endorphins. Different classes than depressants, even though they're overlapping on different receptors. Leads to euphoria when taken recreationally. Opioids bind to opioid receptors by mimicking endorphins. Vasodilator and pupillary constriction, die for respiratory failure. Okay. Cannabis. Marijuana, a mix of all, can be a hallucinogen, also be a depressant of a stimulant. MDMA can be a stimulant or a hallucinogen. Drugs can be classified legal status and how they are abused. Active substance, THC. Cannabis metabolites can be present in blood of users for up to 3 months. Tolerance can increase the amount of cannabis need for impairment. Okay. So it's just a summary of all that information, which I don't really need to go through since abnormal psychology. Psychoactive drugs, depressants and opioids. Okay. Psychoactive drugs alter your consciousness by altering your perception and mood. Depressant, is this just repeating itself? But less overall, more in depth, and just a specific. Okay, axon the GABA. So they both reduce activity of the central nervous system. Alcohol is the most common depressant. Common depressant disrupts REM. We already talked about this. Alcohol is a central nervous system depressant absorbed through the cell membrane. We already talked about that. Purpose used to be called tranquilizer depressants. Induces sleep, reduce anxiety. Side effects: reduce memory or judgment, concentration. Combined with alcohol leads to death because of competitive inhibition. Benzodiazepines are depressants commonly prescribed. Short acting for insomnia, intermediate acting, long lasting for anxiety. Opiates can be used to treat pain/anxiety. Opioids T acronym. Opioids T. Trees natural. Morphine, codeine are opioids, so they're synthetic. They act on endorphin receptors, not a depressant, but can be used for anxiety/pain. Used to treat pain and euphoria. Drugs and can be addictive. They're all addictive generally. Psychoactive drugs, stimulants. Stimulant means it increases neural activity. It can range from caffeine to cocaine, amphetamine, methamphetamine, ecstasy. Between is nicotine. Caffeine can disrupt your sleep. Increased energy can disrupt sleep for several hours. Nicotine and increased heart rate and blood pressure can also disrupt sleep and can suppress appetite, while people gain weight when they quit smoking. At high levels, nicotine can cause muscles to relax and release stress-reducing neurotransmitters. Nicotine is a central nervous stimulant which works as a acetylcholine receptor agonist. Both caffeine and nicotine are physiologically addicting. Withdrawal symptoms for both are from coffee, irritability, difficult concentrating, depression. Nicotine is anxiety, insomnia, irritability, distractibility. Cocaine is even a stronger stimulant. It causes brain to release so much dopamine, serotonin, norepinephrine that it depletes your brain supply. Intense crash and very depressed after it wears off. Usually experience disturbance, emotional suspicion, convulsions, cardiac arrest, or respiratory failure. Amphetamines and methamphetamines trigger release of dopamine, releases for euphoria for 8 hours. Once the effect wears off, experience irritability, insomnia, seizures, depression. Meth is highly addictive. Long term, meth addict may lose ability to maintain normal levels of dopamine because brain tries to adjust to intense highs. So tolerance. Hallucinogens used to alter perception and sensations. There's many types. Some have medical uses. Ecstasy, MDMA, and Molly are synthetic drugs used to stimulate and hallucinogen. Like a stimulant, increases dopamine, serotonin, and euphoria. Also stimulates the body's central nervous system. Effects include high blood pressure, dehydration, overheating, death. Can damage neurons that produces serotonin, which can several functions in moderating mood. Causes hallucinogens. Hallucinogen, heightened sensation, artificial feelings of social connectedness and intimacy. LSD is prototypical hallucinogen, interferes with serotonin, which can cause people to experience hallucinations. Hallucinations can be visual or auditory. Marijuana is a highly mild hallucinogen. Main active chemical is THC with heightened sensitivity to sounds, tastes, and smells. Like alcohol, reduces inhibitions, impairs motor coordination, disrupts memory formation, short-term recall, stays in the body for weeks, so regular users need less of it. Used as a medicine to relieve pain and nausea. Some hallucinogens are used for PTSD treatment. Allows people to access painful memories. Drug dependence and homeostasis. Okay. Homeostasis is how you maintain temperature, heart rate, metabolism, etc. Occurs when you are resting, take place when you take drugs. For example, if you take amphetamines, your body quickly tries to lower your heart rate and get back to normal. Brain is smart about this. Regular might, at the same time of day, it would reduce it. For example, pretend you are a cocaine addict and you're always in the same room when you inject yourself with cocaine. You start to recognize external cues like the room, needle. If you get cocaine, your brain will tell your body to get a head start, lowering heart rate before you take habituation. A classical conditioning term. What happens if you get these cues and don't get you'll get a crash because your body is below homeostasis. No high and no counter for slowing your body has created. If you're in a new location but take the save, you might overdose. This is because your new location, your body is not prepared for reducing heart rate or metabolism. Routes of drug entry. Oral injection, inhalation. Oral is ingesting something, one of the slowest route because they go through GI tract, half hour. Inhalation is breathing, snorting is the fastest because once you straight to the brain. Injections more direct, take effect within seconds. Fastest can be very dangerous. Transdermal drug is absorbed through the skin. Drug in the patch is pretty potent, releasing the blood over several hours. Intramuscular needle stuck in the muscle can deliver drugs to your system slowly or quickly. Quick delivery is EpiPen, given to someone experiencing an allergic reaction when it starts closing airways. Slow delivery vaccines are intramuscular that's in your arm and it'll be sore after a shot. Intramuscular injection is the fastest route of entry. Most abused drugs are injected intravenously. However, faster route of entry equals more addictive potential. Jesus Christ, it keeps going. Okay. When you first experience happiness or reward, your brain is responding. Your brain says, "This was good, let's do it again." The drugs that activate this drug circuit are more and more addictive. Brain releases dopamine, which it acts through the ventral tegment area in the midbrain. The ventral tegment area sends dopamine to the amygdala, the nucleus accumbens, prefrontal cortex, and hippocampus. This is part of the mesolimbic pathway. Different stimulus activate circuits to different degrees. VTA releases dopamine to part of the brain that have dopamine uptake receptors. The amygdala says this was enjoyable. So amygdala controls emotion. The nucleus accumbens controls motor function. Prefrontal cortex focuses attention, puts attention to the cake. You do it again, dopamine is released and you have continuous pleasure. At the same time, dopamine goes up, serotonin goes down. Serotonin is what probably promotes the feeling of sensation. As serotonin goes down, you're less likely to be full or content. Reward pathway is very biological driven. Evidence of the reward pathway comes from animal models. So it's evolutionary based. Scientists gave rats hooked up with IVs that give them cocaine if they push a lever. And when the rats do this, the rats learn quickly to push the lever. Rats will seek the drug and also try to increase dosage if allowed. Addiction and reward pathway takes over rational choices. Negative consequences don't affect the brain. Animal model: if you give a non-addicted rat regular food it likes with a substance that makes it sick, the rat learns to avoid the food. You give addicted and a rat its favorite drug paired with a substance that makes it sick, he still wants that drug. It doesn't care, it needs the reward. Addiction has a physiological component as well. Increased genetic risk. If someone in your family has it, you have increased risk as well. Environmentally, your choices make a difference too, though. So tolerance is the definition telling you that you'll need to have more of a substance to achieve the safe effect. So example, you took cocaine, a lot of your dopamine synapses, postsynaptic neurons have receptors for dopamine. Long-term stimulation can lead to the brain shutting down some receptors because of high levels of dopamine, which is called tolerance. Tolerance is a shift in the dose-response curve that causes decreased sensitivity to a drug due to exposure. With cocaine, you can have a dependence, a feeling you need the drug, emotional state, physiological dependence, you need increased cocaine. Cross tolerance is a reduction in efficiency response to a null due to the common CNS target. If you go through a period of not having the drug, you experience withdrawal effects. Withdrawal effects are generally the opposite of what you're experiencing from the drug's response. So example, opioids, you'll feel increased levels of pain. So it's like a driving factor telling you need to get more of it. Substance use disorders. Okay. Drugs are substances that include alcohol, tobacco, cannabis, opioids, stimulants. So anything that alters your psychoactive state. We have to consider what happens when drugs enter the body and when they exit. Hence, there's two different processes. Intoxication, where the drug enters the body and exerts effect on someone, and withdrawal exists after a period of use. Intoxication refers to the behavior and physiological effect on the person. These are drug specific. Withdrawal is when you stop using for a prolonged time. You get the opposite effect. Acute or post-acute. Acute is for alcohol only 2 days after cessation of consumption, improves seen 4 to 5 days. Post is fewer physical symptoms, more emotional. Kind of symptoms is post-acute withdrawal symptoms: mood swings, anxiety, irritability, tiredness, variable energy, low enthusiasm, variable concentration, disturbed sleep. So post-acute withdrawal feels like a roller coaster of symptoms. In the beginning, your symptoms will change minute to minute and hour to hour. Later, as you recover further, they will disappear for few weeks or a month, only to return again. As you continue to recover, the good stretch will get longer and longer, but the bad periods of post-acute withdrawal can be just as intense and just as long. Once you've been in recovery for a while, you'll find that each post-acute withdrawal episode usually lasts for a few days. So obviously, triggers for most events. After a while, you develop confidence that you get through a post-acute withdrawal. Post-acute withdrawal usually lasts for 2 years, which is just a synapse of what it's talking about, that a withdrawal can last for months or years. Can be triggered for relapse. Can result in substance-induced disorders, conditions that are caused by substance. Substance-induced mood disorders impact anxiety, sleep, sexual function, psychosis. Substance use disorders occur when the drug causes a serious degree impairment in a person's life. Not everyone experiences this. Substance use disorder, we're looking at a problem with their substance use. How do we know if someone has a disorder? Looking at their substance usage. Are they increasingly large amounts, stronger cravings, more time recovering from it? Failing to cut back, experiencing obligations related to work. Second factor is presence of withdrawal. Starts feeling sick or unwell. Suggests you're physiologically dependent, can be dangerous. Withdrawal is specific to a substance. Withdrawal is the opposite. This often occurs for 4 to 12 hours. Symptoms are elevated through the use of benzodiazepines. Reach their peak 2 days after seizing. Also, tolerance is another sign of developing a substance use. Your body adapts and builds a tolerance to a substance. Effects decrease with equal dose. Increased dose to get the same level of intoxication. There are different severities of substance use disorders from mild, medium, and severe. With caffeine only drug for use, which we can develop a substance use disorder. Okay? It's good to know. I'm going to finish this last section on treatment and triggers for drug dependence and then take a break. I'm starting to feel myself start to slip in my attention span. So, treatment and triggers for drug dependence. Drug addiction is a medical problem that has a physiological or psychological component. Treatment for drug addiction addresses both physiological and psychological symptoms. For serious addiction, hospitalization might be needed and the patient goes through withdrawal. To ensure patients doesn't hurt themselves, the patient needs to get used to operating without the drug. To treat detoxification, separating the addict from the drug is required, sometimes requiring strong medication for strong addictions. Often are addressed symptoms such as vomiting, nausea, pain. Opioids such as heroin act on a neural receptor for endorphins to reduce pain and give euphoria. Methadone activates opioid receptors but acts more slowly, so it dampens the high, reduces cravings. For stimulants like tobacco, medication replaces nicotine by delivering low levels of nicotine through patch, or deliver chemically that act on nicotine receptors. In this case, prevents release of dopamine, help reduces cravings. For alcoholics, med blocks receptors in the reward system. Also reduces symptoms, reduces withdrawal such as anxiety, to prevent relapse during this early stage by minimizing negative symptoms. Inpatient treatments are when they're in the hospital or treatment facility. Outpatients are when they're at home, which makes sense. If you're an inpatient, that means you should be in a hospital. Outpatient, you're at home because you're outside of the hospital. Most treatment occur in either setting, just depending on what is best for the patient. Cognitive behavioral therapy is a psychological treatment for drug treatment. Addresses both cognitive and behavioral components of addiction. Patients learn to recognize problematic thought patterns and develop more positive thought patterns and coping behaviors. They learn to anticipate problematic situations and to self-monitor for cravings so they can apply their coping strategies early. Used successfully for patients addicted to alcohol, cocaine, methamphetamine, and nicotine. Skills people learn in CBT are long-lasting, last after therapy ends. Motivational interviewing involves working with patients to find intrinsic motivations to change. Very focused, goal-directed therapy. Few sessions can be doorway for patients to engage in another treatment. So, motivational interviews involve working with patients to find intrinsic motivation to change. Group meetings such as AA or Narcotic Anonymous involves a 12-step program that helps them get through the process. 3 categories of steps. Acceptance, which is acknowledging addiction is a chronic progressive disease that you can't control on your own. Surrender, give yourself over to a higher power and accept help offered through that power and group. Active involvement in meeting and activities can include helping other addicts. Evidence they're helpful, particularly for alcohol. Steps are sequential, but one can experience certain steps repeated over time. Sometimes there are parallel groups meeting for families of recovering addicts. It can help people in addicts' life understand problems and also help their loved ones. Relapse is when a patient can slip and go back. Demands on environment, triggers, and drugs that we're addicted to. So relapse is going back to the substance use disorder. More addicted substances have increased relapse rates. Incurring anything that is associated with a drug can promote more relapse, more likely as well. That's why it's hard for people to stay clean. Say situation, group of friends, apartment, etc. So we will return to attention after a little bit because I'm getting drained and I need a break. So I will return